So this is a very, very simple trial about splinting mallet injuries, and it's simply asking the question, how long do we splint them for? Couldn't get any simpler, could it? Still very difficult to organise. And so far it's me and Abby, and we've got help from Anoni and Helen, but we're about to send out an expression of interest, so we do want people to be involved, please. It's going to be a multi-centre, randomised controlled trial of splint duration for mallet injuries. And it's run through these two organisations at the moment, and hopefully it's going to expand rapidly to involve all of these. So what we're talking about is mallet injury, usually a forced flexion to a finger that's being held in extension, and the bigger bone fragments may be caused by a hyperflexion injury. And we classify them as to bony if there's a fracture, or soft tissue if there's a simple rupture of the tendon. About 1 in 3 years of bony mallet. The majority of these are treated in splints. I think there's not much controversy that that's how most of us would treat the majority of these injuries. I'm not going to talk about surgical management. There are a whole load of different splints available, and there is some evidence that one splint might be better than another, but not much. So here's a sort of treatment algorithm for a mallet injury. There is a surgical route you can go down for perhaps a subluxed bony mallet, but again, slightly controversial. To keep the trial simple and to answer a question that we need to get the answer for, we're just going to look at splinted mallets. Because basically nobody knows how long you need to splint them for. We know that bone heals quicker than tendon, so people typically splint a bony mallet for between 4 and 8 weeks, and a soft tissue mallet for between 8 and 12 weeks. And we got these figures just from a sort of straw poll of asking a few of our friends. If you look at the literature, and there has been a Cochrane review on this, and also quite a good literature review published last month, there's really very little evidence about how best to treat mallet injuries at all. The indications for surgery are not clear, and no one's ever looked at the duration of splinting. And both of these studies concluded there is a need for high-quality, multi-centre randomised controlled trials to answer these really basic questions. So we think that possibly surgeons are splinting patients for longer than is necessary, which leads to stiffness, loss of productivity, and I've got a couple of consultant colleagues in my hospital who I'm treating for mallet injuries, and they complain endlessly about these splints. So all we're going to do is clarify the optimum duration of splinting, and hopefully update the Cochrane review, because there's a big gap in just the epidemiology of mallet injuries, how much patients comply with their splinting, and how patients feel about the splints. It's all a bit touchy-feely out there. Again, a pragmatic study, so we're going to let the treating clinician decide whether or not the patient needs surgery or whether they can be treated in a splint, and we'll let the treating clinician decide what sort of a splint. All we're interested in is how long to splint for. So there'll be 4 arms. There'll be bony, divided into short or long duration of splinting, and soft tissue, likewise divided. The inclusion criteria will be simple, adults able to understand, but we'll probably exclude children just because it's harder to include them. An isolated injury, not too old, not requiring surgery, and that's at the discretion of the treating clinician. Outcome measures, always in the literature, people have looked at correction of the extensor lag and range of movement of the distal interphalangeal joints. Nobody's reported pain or long-term pain. No one's looked at patient satisfaction and compliance, and no one's looked at functional outcomes. So designing a patient-reported outcome measure will be an important part of this, because actually, does it really matter if the thing's a bit bent? It's all about pain and function. So the next steps to complete the systematic review, and Anoni promised me it would be completed by today, so if she says she has to buy me a journal. I'm going to the Bristol Clinical Trials Unit tomorrow to discuss it with them, and we'll be surveying EPO practice soon, and an expression of interest is prepared, will be sent out imminently before we go on the study, very much along the same route as I know. And of course, it's not just about acronyms. Very importantly, you've got good logos.
Okay, great, thank you. So BACPRESS has approved this as well at the research committee meeting today, so BACPRESS will be supporting this project. We have a quick question. Are we going to include the hand therapists? Yes, we are. The British Association of Hand Therapy are linked in with the RSTN, and they will be involved on the steering group and working party. Brilliant, fantastic. I'll take one question from the floor, one quick one if you have it.
Well, it's always been extensive lack in all the studies that people have done, but actually we think probably patient-reported outcomes are more important.
So
So we don't have a single primary outcome.
we haven't decided that yet because we based on consensus opinion from surgeons, UK survey and patient integrations, then we'll decide that.